Hello everyone, welcome back to this week's EKG. We have an exciting case for you today. This is a 62-year-old male who was found unresponsive and very cold during the winter behind a gas station. So the crew is very suspicious about why he could be altered when they got there. They found a set of vital signs that looked like this. He had a heart rate of 64. He had a blood pressure of 98/60, so a little bit low. He was setting 87% on room air. Sugar was 102 and his temp was 82 degrees, so very cold in the setting of probably environmental exposure. So this is the 12 lead that they get as they're trying to figure out his source of altered mental status. I applaud them for getting this because it wasn't clear they had any cardiac issues, but they get this 12 lead and this is what they see. So take a look, see what you think, and then we'll go through it together. This is a pretty classic finding here. We'll try to read this like we do every single time. So we'll start with our rate. Computer's saying the rate is 64. I usually look for a QRS that matches up with a broad, thick red line, and then we count down. So 300, 150, 100, 75, 60, right around 60, 64. I agree with the computer. Looks good. We move on to our rhythm. So 2 questions here. Is there a P wave before every QRS, and is this a regular rhythm? Looks pretty regular to me. I'll give him credit for that. In terms of P waves, I'm just not seeing them. I typically look in lead 2. Sometimes you can look up in V1. There's some like baseline artifact here, but I would actually think due to his core temperature, that might be shivering. You could maybe call it like a subtle or slow atrial fibrillation, but this is not a sinus rhythm. And because we have a wide QRS here, which we'll get to in a second, it's probably an accelerated junctional rhythm, not coming from the sinoatrial node, a little bit slower, coming from somewhere else a little further down the electrical pathway here. Axis, we look at leads 1 and leads AVF. Our QRS vector in lead 1 is up, our left thumb is up, QRS vector is mostly up in AVF. 2 thumbs up. We do have a normal axis here, so he's got something normal going for him here. And then our intervals. So I already mentioned that we have a wide QRS. This is greater than 120. It's actually pretty wide. And then we look at our QTC, 451. So that is long as well. The more concerning thing here is the very wide QRS in the setting of an idioventricular rhythm. Something's going on with this conduction pathway. And then as we move on, the segments you've probably wanting to been look at from the beginning are our ST segments. So I usually start 2, 3 AVF. I don't see any ST elevations here. Maybe a little bit here, but it's kind of hard to tell, and nothing looks really typical, right? As we move to our high lateral leads again, that kind of looks near baseline. But as we move to the anterior and septal leads, there's T-wave inversions, ST depressions, and then even maybe ST elevation in these like lateral leads, right? Did you call this systemi though? I don't know, because you have elevation, but I'm not really seeing reciprocal changes anywhere, and it doesn't look like a classic STEMI, right? The thing here that's sticking out to me is this really weird looking, like kind of biphasic wave right here after your QRS, but there's a wave right after the S wave leading into the T wave. Not sure what to make of that. Well, what you're seeing there is actually an Osborne wave, and this is something that's very indicative of hypothermia. And you're looking at this J point here. So the J point is actually a single point in time on every 12 lead that you see, and it's located right after the QRS complex, and it's as the S wave leads into the T segment. So this is a normal J point. Sometimes the J point can be elevated, sometimes the J point can be depressed, but in an Osborne situation in hypothermia, what you see is actually a wave. It's an extra wave after the J point there. It's kind of slow and it's slurred, and depending how big that wave is, it can tell you how severe the hypothermia is. So the wave magnitude actually directly correlates with the severity of the hypothermia. And so if we look at a couple more examples here, I borrowed these from Life in the Fast Lane because not every J-wave is going to look the same. But you can see that on this one here, after the QRS complex, you have another slow upslurred wave before you hit the T wave. That's another J-wave. And you can see it's a little bit smaller here, a little more subtle, but it's still there. Right after the QRS, you have a little tiny wave. And so when you're thinking about hypothermic patients and the EKG abnormalities that they can have, typically early on in hypothermia, you're going to have a tachycardia. But as things get more cold and actually more frozen, everything's going to slow down. So you'll see bradycardia. You can see junctional rhythms like we saw with our patient here. You're going to get longer intervals, so a wider QRS, a longer QT. Then you'll start to see those J waves. And as the patient gets colder and more severe, the J waves are going to get more prominent. Ultimately, they can go into VFib, realize that they're at a high risk for arrhythmias as it is as the patient gets really cold. And so, in summary, what you're seeing on this 12 lead here, you're seeing an idioventricular rhythm that's accelerated with a rate of 64, wide QRS, and then Osborne waves here, suggestive of severe hypothermia in this patient. And so you're probably wondering, well, what do I do about that? How do I treat this patient? Actually, you just do your best to rewarm them. If you can correct the temperature, you're going to correct a lot of the other abnormalities. So really focus on being gentle, especially if they're very, very cold. You don't want to really harshly move them or upset anything because they could easily go into ventricular fibrillation. But you do want to be very gentle when you move them and then just focus on rewarming. So get those cold, wet clothes off. Maybe use your rewarming packs. If you're fortunate enough to have warm IV fluid, you could try that. But if you don't have warm IV fluid, I would stay away from adding any fluids to this mix. If he's hypotensive, I would tolerate that. At least he's got a blood pressure. Same thing, don't be too aggressive with bradycardia either, because electricity or atropine or even epinephrine might upset an already kind of irritable heart. And so bradycardia is allowable. A certain degree of hypotension is allowable. You really do, if they're very severe, you do want to get them to an ECMO center because that's going to be probably one of the sources of the best outcome for them if you have that available in your area. And here in Albuquerque, both Presbyterian and UNM have ECMO programs in their EDs. So that is all for today. I hope you learned something about hypothermia as we approach winter and you're ready for these patients, and I'll see you next week with a new case.